All right, here we go. Hello, and thank you for watching this program on the best rehab codes. There's no audio taping or videotaping allowed, and any unauthorized reproduction, dispensing, forwarding, or copying of this target coding presentation is illegal. The information contained in this presentation is for educational purposes. It's not intended to be a substitute for your thorough clinical decision making. Again, target coding is not, we don't perform legal services. We don't engage in providing legal services. CPT is a registered trademark of the AMA, and I've made every attempt to make certain that the information in this presentation is 100% accurate. However, it's not guaranteed. Let me tell you a little bit about myself before we get going. My name is Dr. Marty Kotler. I am a chiropractor. I practiced for 16 years. About 12 years ago, I started a company called Target Coding. I then got my certification in CPT coding. I'm also a certified professional compliance officer. My areas of expertise include coding, HIPAA compliance, documentation, Medicare, how to create compliant cash plans, and ICD CPT code pairing. I've written many training manuals on billing, coding, and documentation for chiropractors. I write articles for Chiropractic Economics and Dynamic Chiropractic. I'm a speaker for the Coding Institute, Parker Seminars, Foot Levelers, and I'm also a guest speaker for many state association conventions nationwide. Okay, let's dig in here and talk about the best therapeutic procedure codes, also known as rehab procedures. Let's begin with a little bit of an introduction here. Therapeutic procedures. We're not talking about modalities. Modalities like traction and hot packs and cold packs and ultrasound. We're not discussing those today. We're going right into therapeutic procedures. So, therapeutic procedures is a manner of effecting change through the application of clinical skills. That's important. I'm going to be focusing on that as we go through the presentation. Application of clinical skills and or services that attempt to improve function. So application of skills, improve function. I'm going to get back to that in a few minutes. One-on-one patient contact is required. One or more areas each 15 minutes. So these are time-based codes. They do require one-on-one patient contact. So now let's talk about who can provide these services. There are two types of categories. Qualified healthcare professionals, like chiropractors, medical doctors, nurse practitioners. Qualified healthcare professional is an individual who is qualified by education, training, licensure, who performs a service within his or her scope and could report these professional services. So again, chiropractors, medical doctors, osteopaths, nurse practitioners, physical therapists, physician assistants are all considered qualified healthcare professionals. Clinical staff member, different. A clinical staff member is a person who works under the supervision of a chiro, a PT, or an MD, or other type of QHP, who's allowed by law to perform the service and assist in the performance of the service, however, cannot individually report the professional service. I bring this up because there are some health plans, especially in the PI world, that are making a big deal about this. State Farm and some other major auto accident carriers are getting very picky as to who can render the service. So, in certain states throughout the country, CAs can perform most of the services like traction and oversee therapeutic procedures. In some states, they can perform a portion of it. Like there's one state where the CAs can put the stim pads on the patient, but they cannot turn the machine on. Yeah, I know, that sounds a little silly. And to get even sillier or more ridiculous, in my opinion, there are some states where CAs cannot do anything. There are some states where CAs cannot even put a hot pack on a patient. So you want to make sure that you're not going to get caught with your hand in the cookie jar by if there's an audit, an investigation, and it's found out that you're providing services by a clinical staff member where it had to be a QHP. So check your state scope of practice. Make sure you're doing it right. That's compliance. Okay, now we're going to get right into the first therapeutic procedure code, 97110, therapeutic exercises used to develop strength, endurance, range of motion, flexibility. You might want to jot this down. It's an acronym. It's called SERF, S-E-R-F. S stands for strength, E stands for endurance, R stands for range of motion, F stands for flexibility. So there are 4 parameters right there within the definition of that procedure code. With this particular code 97110, you have to accomplish at least one of those parameters. The most common one that I find with the thousands of doctors that I've worked with over the last 12 years is to improve range of motion. Yes, you can use it to improve strength and endurance, but the most common one is the R in that acronym, to improve range of motion. So if a patient is coming in and you're trying to improve range of motion, well, what should your documentation show that the patient has a lack of? You got it, range of motion. And one of the main differences between a modality like ultrasound and traction and a therapeutic procedure is that with a modality, it's the device that you buy that dictates the code you bill. When it comes to a therapeutic procedure, it's not based on a piece of equipment. It's based on your intended outcome. What are you trying to accomplish? So if your goal is to improve range of motion, your notes better show that the patient has some sort of lack of motion. So these therapeutic exercises can be performed either an active assisted, or passive approach. Some of the doctors I work with, it's all passive. Some it's all active. It could be a combination, little here, little there. Used for restriction of joint motion, strength, functional capacity, mobility. Your documentation must show objective loss of joint motion, strength, mobility. If you're working with PI patients, I think it's a good idea to get a goniometer or dual inclinometer and get those degrees. Many doctors are eyeballing it, yet they're putting down certain degrees. I don't recommend that. If you're eyeballing the range of motion, then just use mild, moderate, severe restriction. Now, can the patient perform the exercises without the application of provider-skilled assistance? This is what I was referring to earlier, the application of clinical skills. If you have a patient that's coming in with, let's say, let's take a patient. Mrs. Jones comes in. She's got low back pain and low back stiffness. And you want her to perform certain exercises to improve range of motion, to decrease stiffness in her lower back. What are you going to have her do? Are you going to have her lie in a gym mat and do some abdominal crunches? Do you have fancy equipment, balls, bands, tubes, weight machines? You should outline that in your plan of care, which I'm going to show you an example of the difference between how to outline a therapeutic rehab procedure in a plan of care versus a SOAP note. But what clinical skills are being applied by either you, the doctor, or a staff member? So if a patient is doing, let's go with a simple exercise like abdominal crunches, core exercises, and the doctor or staff member is overseeing the patient, providing clinical skills, verbal cues, making sure the patient isn't injuring him or herself, so you're providing some assistance there. But let's say after, 10, 12 visits, the patient is able to perform the exercise without assistance, without the fact that the patient might injure him or herself. The patient can do this exercise now at home, all alone, without a problem. So when it gets to that point, it's not a billable service. It becomes not medically necessary. So when something's medically necessary, that means it's typically insurance payable, right? I equate those two. Medical necessity means you can get paid by insurance. If it's labeled or considered not medically necessary, yet it's clinically indicated or chiropractically necessary, but not medically necessary, according to a health plan, then it becomes a non-payable service. So this is very common in the chiropractic profession. Medicare has found chiropractors to be billing for not medically necessary chiropractic spinal adjustments, yet they were being billed as if it was active treatment. So here we have a similar situation where you could be accused of performing a service that is not medically necessary, but you think it is, and it could be because there's no clinical application being applied by the doctor or staff member, and there's no improvement in function. Let's go to the next one, 97112, neuromuscular reeducation, used to improve movement, balance, coordination, kinesthetic sense, posture, and or proprioception for sitting and standing activities. Okay, this is an excellent code. Many chiropractors use this code. These codes are also used very commonly by physical therapists. All of these codes that I'm sharing with you are shared by actually many healthcare professionals like physical therapists, chiropractors, occupational therapists, speech-language pathologists, osteopaths, physician assistants, nurse practitioners, athletic trainers, massage therapists, all share in many of these codes. So 97112, excellent code. It's used to improve balance, coordination, kinesthetic sense, proprioception. So again, if you're going to be using this service to improve, let's say, proprioception, what should the patient have a lack of? Yes, you got it, proprioception. It's reasonable and necessary for impairments which affect the body's neuromuscular system. PNF, it's a pretty common term used in chiropractic, proprioceptive neuromuscular facilitation. Could also be used with BAPS boards. You may have heard of BAPS boards, balance boards, BAPS boards. BAPS is an acronym for Biomechanical Angle Platform System. Now, there are some health plans that have a big problem with this particular code, and they say, well, this is a payable service only if the patient has some sort of advanced neuromuscular skeletal problem like multiple sclerosis, or the patient has suffered from a stroke. I personally disagree with it, but I'm not paying your bills, so you need to contact all the carriers that you bill prior to submitting this code to see what's their position on it. So do your research. Again, this code can be used, in my opinion, can be used for non-advanced neuromuscular skeletal conditions. I would say most plans are okay using this service, but again, need to be careful. Depends who you're billing. Cash patient, you can use this with your best intent. So let's move on to the next code. 97140, manual therapy techniques. This has a lot of information built into this code. This could be used for joint mobilization, soft tissue mobilization, manual traction, manual lymphatic drainage, manipulation, myofascial release, non-injectable trigger point therapy, acupressure. There's a lot of different terms that can be used to categorize this particular code. Now, what's the purpose of this? For every service you provide and every diagnosis you come up with, you have to have justification. So what's the reason, what's the clinical rationale for billing 97140 or performing it? Well, it's typically used to treat restriction in soft tissues in the extremities, the neck and trunk. It could be used in an active or passive fashion to affect changes in the soft tissues, articular structures, vascular systems. Examples could include facilitation of fluid exchange, restore movement in acutely edematous muscles, and stretching of shortened connective tissue. It's used when a loss of motor ability impedes function. So it's an excellent code. Many doctors use it. However, there's a CCI edit on this. CCI means Correct Coding Initiative edits. This is a federal program that maintains a system of coding edits to be utilized nationally by all Medicare carriers. However, most regular health plans, including PI, use the same rules. I find that to be inappropriate, but I don't make the rules. I just share them with you. The purpose of these CCI edits is to electronically detect codes billed that would not normally be used together. So these CCI edits, they require that manual therapy, also neuromuscular reeducation and massage 97124 be performed in a separate anatomic site than the chiropractic adjustment. So if you do that, then you're going to want to attach the 59 modifier in order to indicate that it's a distinct procedure and it's being performed on a different anatomic site. I've been teaching this CCI edit on 97140 for many years now, yet many providers are still doing it incorrectly. I am working on an audit right now, a pretty big one, from United Healthcare Optum, where they're asking a provider for thousands and thousands of dollars back. And one of the main reasons is this edit on the 97140, and this doctor, it just was not following the rules. I'm looking at the notes. I'd love to be able to help this provider. However, his notes clearly say that he did the manual therapy and a chiropractic adjustment in the same anatomic site. It's going to be very difficult. I have been able to help some providers overturn it with a much deeper dive into manual therapy, trying to explain to the health plan that it's a separate structure, not necessarily a separate anatomic site. Sometimes it works. Most of the time it's a difficult denial to appeal and overturn. So just make sure you know the rules. It must be in a separate anatomic site. And because of the 5-9 modifier is very important. Now, you know, the OIG, many years, Office of the Inspector General, found that the 59 modifier was billed incorrectly nearly 40% of the time, resulting in millions and millions of dollars of overpayments. So the 59 modifier is a frequent target of audits. But if you're using it properly, you should be okay. I mean, just think about it. If you're driving your car down the road, you're not going over the speed limit, you have your license, registration, your insurance card with you, you don't have any drugs or guns in the car, and you get pulled over. You shouldn't have anything to worry about, right? You know, it could just be a random spot check. Maybe, you know, you were mistaken for someone else, but you shouldn't have anything to worry about because you didn't do anything wrong. It's still nerve-wracking. It could still, you get pulled over now, let's say you were on your way to the airport and now you miss your flight. It could still be a big inconvenience. However, you're not going to be accused of any wrongdoing. So my feeling is the same with the 59 modifier and the 25 modifier and the 52 modifier. If you're using it properly and you get pulled over, yes, it will be an inconvenience, but you will never be accused of any wrongdoing. So make sure you're doing it right. Now, the 59 modifier, because of all the confusion and the wide variations in circumstances in which it can be used, it's confusing for many staff members and providers. And it's one of those rare modifiers that bypass the CCI edits. Let me explain that one. See, if you build a CMT code and 97140 without the 5-9, there's a good chance the health plan is going to bundle the two together and only pay you for the CMT. Now, if you rebuild it with the 5-9, it gets paid. So you see how the 5-9 modifier, it's one of those rare modifiers that bypass the CCI edits and allow you to get reimbursed. Just make sure you can back it up in your notes. Many doctors have been caught with their hand in the cookie jar. They're using the 5-9 modifier incorrectly. All right, so now I mentioned a little bit about code pairing. Pairing your CPT codes to your ICD-10 codes is very important in order to justify treatment. You have to justify everything you do. Years ago, when I first started practicing, a patient would come in and say, "Hey, Dr. Kotler, I have back pain and it's radiating down into my leg." I just automatically diagnosed sciatica. I didn't do any ortho neuro tests. I didn't really do anything, and I was getting reimbursed. It wasn't an issue. Well, times have changed. Those of you that deal with certain health plans, you know you cannot just diagnose sciatica without being able to justify it by certain tests and questions and exam findings. So you need to be able to justify your diagnosis codes, and you need to be able to justify through the correct verbiage your CPT codes. So I mentioned earlier with 97110, how do you justify it? You're using to improve range of motion, flexibility. If you're going to use manual therapy, you're using it to stretch, shorten connective tissue as an example, and you want to pair the justifications at each one. So I look at it just like, you see the graphic with wine, food and wine pairings. You know, I enjoy going to food and wine festivals. It's one of my most favorite things to do, and I like to, you know, learn from the experts. You know, so, you know, red meat typically pairs with red wine, and white wine typically pairs with seafood. So here's an example. Manual therapy, 97140. There's your CPT code. That pairs beautifully with diagnosis code right shoulder stiffness or myofascial pain syndrome. A little bit more about pairing when it comes to ICD-10s. Let's say you diagnose a patient with some sort of sacroiliac joint condition like sacroiliac joint sprain, S33.6, or sacroiliitis, some, you know, sacroiliac, you know, subluxation, something to do with the SI joint. So let's say you submit a claim to a health plan. Now, this also applies to malpractice cases and state board issues. When I take on a client and I'm educating the doctor and the staff, it's to protect them from three things: getting paid and getting audited by insurance, making sure they're maximizing reimbursement. That's number one. Number two is risk management. I spend a lot of time making sure the doctors are preventing malpractice. And number three, preventing state board issues. You know that a cash patient could file a complaint against you with the state board. You know that, right? Yes, you do know that. I'm working with a doctor right now, cash patient, no insurance at all. After about 15 visits, the patient said, I want my money back. The doctor said, I'm not giving you your money back. The patient filed the complaint with the board. Now the board asked the doctor for the financial records, all the documentation. This is a cash patient. The board now came back and said, well, good news and bad news. Good news is you don't have to give the money back to the patient, but your documentation does not support what you're doing. Your documentation is horrible. Every note said SALT, which is an acronym for same as last time, so he's in big trouble. The board is really coming down on him really hard. He has to get an attorney. He had to hire me to help him with his coding. He has to put together a corrective action plan. He's going to be fined, and there's penalties involved. I mean, they're on the border of almost wanting to take his license away. It's become a big deal. Wait, this is a cash patient. Yes. So if you're going to come up with a diagnosis, even on a cash patient or in a malpractice case, you diagnose somebody, you want to be able to justify it. So if you submit a claim with a sacroiliac sprain diagnosis and now you're being questioned, hey, Dr. Kotler, how did you come up with that? I would recommend you have some of these answers. Well, the patient had pain in that area. Orthopedic tests, Yeomans, Ganslins for Patrick, do a few of these. This will help you justify the diagnosis code. We found some palpatory tenderness, subluxation, hypermobility, pelvic tilt. May take x-rays to rule out SI joint pathology. Here's another one. You ever diagnose a patient with a cervical radiculopathy? So here you go. You're on the witness stand. So Dr. Kotler, we see that you diagnosed a patient with cervical radiculopathy. How did you come up with that? Hopefully you have a good answer. Well, the patient had pain from the neck radiating into the arm. Ortho tests include Jackson compression, Valsalva shoulder depression. You know, some of these ortho tests you may have forgotten how to do. Just go to YouTube and Google them. You'll see beautiful videos that show you, remind you how to do shoulder abduction or Sperling's test. Do a couple of these. Now, I know some chiropractors that are subluxation based, very straight, chiropractic offices. They go, Marty, I don't do ortho tests. I don't do neuro tests. I don't have a reflex hammer. I don't own a blood pressure cuff. If that's the case and there's a malpractice case or a state board issue, it's going to be tough defending it. Do a few of these tests: neuro tests, dermatome changes, myotomal weakness, positive nerve stress, chiro tests included limited motion, subluxations. Again, you want to be able to justify the services you're rendering. Oh, and actually, this is a page out of a book I recommend to all my clients. It's on the best CPT and diagnosis codes to maximize reimbursement, and this book has about 25 of the most common diagnosis codes and the ortho, neuro, and chiro tests to support it. All right, let's talk about the next most common and best rehab code: therapeutic activities. Direct one-on-one patient contact. Required use of dynamic activities to improve functional performance. All of these codes, again, are time-based. You could bill them in units. Involves functional activities, this code. A lot of people call this code the ING code because whatever you're doing, whatever you're billing for, it better relate to bending, lifting, reaching, carrying. It's a multi-parameter code, so you have to accomplish 2 parameters, at least 2, and it has to be related to some sort of functional activity. This particular CPT code has the highest RVU. If you look in fee schedules across the country, this one pays the most out of all of them. It should be part of a treatment plan directed at a specific outcome. Document clear correlation between the type of therapeutic activity performed and the patient's underlying condition. It's reasonable and necessary for a broad range of exercises that involve movement. The activities can be a specific part of the body or the entire body. An example might be to increase flexibility of the quadratus lumborum muscles while activating and stretching the hamstring muscles to improve the patient's ability or capacity for standing or walking, and certain exercises to improve outcomes with strength, proprioception, endurance. Now let's discuss. I've been mentioning time codes. There's total time. I call it total time versus rule of 8. Everybody has their own way of describing these. I'm giving you my version. There's total time and there's rule of 8. Total time is what Medicare uses and United Healthcare, where 1 unit is 8 to 22 minutes, 2 units 23 to 37. But just want to share with you how to calculate these units. So just think about it. If 2 units is a minimum of 23 minutes, so let's say you do 97140 for 23 minutes, and then you follow that with 97110 for 23 minutes. On the surface, you would think, wait, I could probably bill 2 units of each for a total of 4 units. But if you're billing Medicare or United Healthcare, now I understand Medicare doesn't pay for these codes, I get it, but many doctors listening to this presentation may employ physical therapists, so it applies to them. But United Healthcare, Medicare, say total time, that situation, you'd only be able to bill 3 units. Why? Because the total is 46 minutes. 46 minutes falls in the 3-unit category. Now, you want to bill 4 units, got to get to 53 minutes. 97140, 30 minutes, 110 for 23 minutes, that totals 53. There you go. Now back to the first example, 97140 and 110, 23 minutes each for a total of 46. You could only bill 3 units, so how would you bill this? You'd bill 2 units of one and 1 unit of the other, right? But which one would you pick? Pick the one that pays more. Most of the time, it's 97110, although most people think 140 pays more. Next, the rule of 8. Look at this. If a health plan follows the rule of 8, 8 minutes of 140, 8 minutes of 110 for a total of 16, and you can bill both units? Yeah. Check with all the plans you bill to ensure that you're using the right calculation of units. Now, I mentioned this earlier, care plan versus SOAP note. I'll give you an example here utilizing code 97110. In your care plan, now a care plan, treatment plan, plan of care, whatever you want to call it, should consist of 6 things: history, exam, diagnosis, services rendered, schedule of care, and the procedures you're going to be rendering, and the goals. Again, history, exam, diagnosis, goals, services rendered, and the schedule of care. So that's what I consider a plan of care. Within your plan of care, let it all hang out. Let your hair down. Explain everything in that care plan. It's worth the extra 15 or 20 minutes it takes to put it all in your care plan, because you could use that as your reference. You could use that as your guide. If anybody questions you, you could say, well, refer to my care plan. You'll see it's all laid out. So in your care plan, I would recommend you put something like this in it. The initial 12 visits will include therapeutic exercises with direct one-on-one contact to the, let's say, lumbar region, if you do active assisted or passive approaches, and the purpose to increase range of motion in this example, and explain your protocol. You're going to be using balls, bands, tubes, an exercise bike, weight machines. Explain it in extreme detail. And then on each individual SOAP note, all you need to do is put exercises, lumbar, 15 minutes. If a case manager, reviewer, an auditor, an investigator is looking at your SOAP notes and they, hey, we're not going to approve, you're not explaining your protocol, you're not explaining or describing who's actually performing the service, you could say, whoa, time out. I'm just going to have you refer to my care plan. It's all there. All right, just a few closing comments. Check with all the carriers you bill prior to submitting claims to ensure that it is compliant. We can't guarantee this information will guarantee payment. Target Coding is not responsible for any laws, rules that change following this presentation, and you know they change all the time. So do your best. Attend seminars, webinars, join your national and state professional associations, be a sponge. Before we get to questions and answers, let me give you my contact information here. It is, the email is info@targetcoding.com. The website is targetcoding.com. Telephone number 1-800-270-7044. Our HIPAA secure fax number is 1-844-831-2347. We created a HIPAA secure fax number for doctors that want to send us patient information to review. Do not send it to us. There are many doctors that send us information over a Gmail or an AOL account, and they're attaching patient EOBs that have the patient's name and social security numbers. Don't do that. Don't send that to anyone over an open email like that. So if you're going to fax us some information about your patients, you don't have to white out or black out the patient's name. We have a HIPAA secure fax number where you could fax us the information. That's why we created it. And yeah, before we get to questions and answers, this is the book I was referring to. It's called The Best Chiropractic ICD-10 and CPT Codes to Improve Reimbursement. It has a lot of good information in here. In Chapter 1, it has the code pairing. This gives you the clinical rationale and the documentation suggestions, and then the pairings of 97110 with the diagnosis codes in the cervical, thoracic, lumbar regions. This is also in this is in Chapter 3 of the book. It gives you the tests and the diagnosis codes and the ortho-neuro-chiro tests. And this is in also in Chapter 1. It gives you these cheat sheets, these little quick guides. This one is on the best personal injury codes. And then, yeah, you know, it's interesting. Work with thousands of chiropractors over the last 12 years, and I'll get hit with questions that are more clinical. And so I did a little research. Like, I'll have clients calling me, say, hey, Marty, what's the difference between radiculitis, radiculopathy, and myelopathy? What's the difference between myalgia and myositis and myofasciitis? What's the difference between a disc disorder and a disc displacement? And you would think these are the things that you would be taught in chiropractic college, but yet it's not so. I put together some frequently asked questions there. That's also part of the book in Chapter 3. Here's and long-term treatment. Of course, you want to use long-term treatment diagnosis codes if they are indeed available. For example, a patient comes in with sciatica and muscle spasm. Report sciatica as the primary diagnosis, except for Medicare. There's an exception, right, to that rule. Oh, this has become a big deal. OIG compliance. Those of you that treat Medicare patients under the Affordable Care Act, also known as Obamacare, you're required to have a compliance plan. And even with the new administration that's possibly trying to repeal or replace, this is not going away. This was passed bilaterally, bipartisanly. All of the HIPAA rules and OIG rules are not changing even with the new administration. So OIG compliance has become a big deal because of the 8 OIG reports that have come out over the last 8 years. So if you treat Medicare patients, there's more of a chance nowadays that you're going to be asked for your notes, and if your notes are not good and they look like you're billing for maintenance care, but you're getting paid as if it's active treatment, you could be accused of a false claim, and that can result in penalties and fines. Put together a nice OIG compliance manual. You could probably do it on your own, but if you want us to do it, we have an excellent one. It doesn't take long to create. It's only about 35 pages. It's not overwhelming and crazy. We've made it simple, basic for just about any chiropractic practice. We provide you with customizable policies and procedures. We show you how to do internal audits, which is another thing which is mandatory under the Affordable Care Act, that if you treat Medicare patients, you have to do internal audits. We've created our own little chart audit tool. Members of Target Coding, if you want a copy of our chart audit tool, please send an email to info@targetcoding.com. Yeah, we also offer HIPAA compliance programs. This has also become a big deal. Why? Because of hacking and cybersecurity. Imagine if you went into your office tomorrow morning, you turn on your computer and your EHR system is not turning on, you've lost the data, something ain't right, you've been attacked, you've been hacked, malware, worms, virus. You now could be faced with a possible HIPAA violation. HIPAA violations start at $50,000 penalties. It's just not worth it. Become proactive. That's what the biggest, most successful practices that I work with do, these things because they know it's important. It's just like, you know, I have some friends that are very, very wealthy. They have these huge life insurance policies because they really care about their family and they really care about their, you know, their financial situation. So to me, these HIPAA and OIG manuals, it's like additional insurance for your practice. It could prevent losses and penalties and fines. So we offer HIPAA compliance. We have a whole bunch of seminars coming up and webinars. Check our website. We also offer memberships. Just about every week we do paid webinars. This one was a free one, but we offer many paid webinars, and some are CE approved for your license renewal. So as a member of Target Coding, you could attend those for free. So we have basic, gold memberships, platinum memberships. We also offer a free coding and compliance evaluation. Here's our contact information again. Email info@targetcoding.com. Website targetcoding.com. Telephone number 1-800-270-7044. HIPAA secure fax number 1-844-831-2347. And let's take a look and see what questions have come in.